Thank you so much for that detailed and touching description of what's going on in the training right now and the critical issues that you're seeing. I'd like to invite our last two speakers to come back up, as well as introduce Annie Mithoefer. Annie is a registered nurse living in Asheville, North Carolina. She has many years of experience treating people in PTSD in private practice and with her husband Michael, and leading holotropic breathwork group workshops. She and Michael completed the first MAPS-sponsored phase 2 clinical trial testing MDMA-assisted psychotherapy for crime-related PTSD, and a subsequent study with military veterans, firefighters, and police officers, as well as that pilot study treating couples that I mentioned before. She's now focusing on offering MDMA therapist trainings and on supervising therapists in the ongoing phase 3 clinical trials. She's a certified holotropic breathwork practitioner and trained in Hakomi therapy. So please welcome Annie, along with Leah returning to the stage and Joy returning to the stage. Thank you.
Annie, I'll let you sit next to Michael.
So we have a really amazing group here and a wealth of knowledge about training and education and kind of what needs to happen to take this road to commercialization, as you've just heard. I have a couple of questions that I'd like to get us sort of kick things off with, and then we'll go to the audience questions. So if you have questions and you want to get them concisely whittled down to a sentence and get on that line, that would be fantastic. A couple of questions. Let's see, where would I like to start this one? I would like to know. Let's go back to this sheet. Yes. So this is actually a question for Joy, going back to where we started. You talked about REMS and you talked about patient access and what the process will be looking for. And I know that the research is focused on MDMA-assisted therapy for the treatment of post-traumatic stress disorder, but the criteria for that are pretty narrow and specific. And I'm curious if you have thoughts as to what will the level of flexibility be post-approval? Will there be the possibility of off-label use of this treatment and or more flexibility around PTSD criterion and severity?
Yeah, great question. Is this on?
Yes.
Okay, great. So we are pursuing approval for specifically a PTSD indication. As you alluded to, Elizabeth, the diagnosis of PTSD can be a bit squishy, to use a very technical term. But we would not expect that post-approval, the diagnostic criteria would be the same as what's been used in our clinical trials, where we've used like the CAPS, which is a clinician-administered PTSD scale, which Michael and Annie can speak much more fluently to. But those types of scales are not typically used in clinical practice, and so it's our expectation that patients would need a PTSD diagnosis, but that could come with come through like a DSM-5 criteria, for example, as opposed to necessarily like a CAPS type score. We can't speak to off-label use as the sponsor of the product. Again, we are pursuing an indication for PTSD. I think it's commonly known that there is a lot of off-label use of various medications, particularly psychiatric medications, but MAPS BBC would not be promoting that in any way.
Can we ask a different question, a follow-on question to that?
Sure.
That's very important. Joy, is it your understanding that REMS can restrict off-label use? Is it possible that the REMS could restrict it to one diagnosis?
It's possible. It's not what we currently expect in the REMS. We don't expect that there would be a requirement that the patient would have a documented diagnosis. But as we'll talk a little bit about tomorrow in Amy and my talk, the REMS is a complicated process that's subject ultimately to the FDA's approval at the time of the drug approval. And so it's going to, unfortunately, I think, be an open question until very, very close to a prospective launch.
Excellent. Thank you so much for explaining I'd love to hand it over to our audience for a couple of audience-generated questions. Let's hear what you would like to hear.
Hi, Larry Luck. I have a question for Ms. Cooper. What IP or other form of exclusivity does MAPS have for MDMA? And then how does that change for naturally occurring substances like psilocybin? And then maybe contrast that with other approaches such as compass pathways. How are developers navigating the balance between broad access and a traditional pharma model to sell drugs that recoup the cost of development?
Yeah, there's a lot packed in there. I'll try to be really brief because I know there are probably lots of questions and for others on the panel. So obviously, MAPS does not have a patent on MDMA. This is in the public domain. What we do expect to have if the product is approved is what's called data exclusivity. So all of the data, the clinical data that Michael and Annie have helped to generate through our clinical trials, toxicity data, lots of other data that we are investing quite a lot of money to generate at the standard of the FDA would be proprietary to MAPS. So we would take that to the FDA to hopefully get approval. And no other manufacturer of MDMA could reference that data to get approval to market their own kind of MDMA product. So that period of data exclusivity is 5.5 years. If we do a pediatric study, that gives us an extra 6 months. So effectively, we expect to have about 6 years of exclusive rights to market MDMA in the US. That period of the nature of data exclusivity and the length of time that's provided varies by market, but in the US, again, that would be about 6 years. So technically, it could be possible for somebody else to come in the next couple of years and replicate all of the work that MAPS has done over the last 20 years and try to market their own product. But we think that's pretty unlikely for a variety of reasons I can speak to. I think I might defer the discussion about sort of other companies' IP strategies, if that's okay. We can come back to it if it's important, but I just recognize it's a very complex topic, obviously, and I know that there are a lot of other questions. So, thanks.
Okay, thank you so much. Let's hear the next audience question.
Hi, I was just wondering, do you have a plan to navigate the already burned out health insurance psychiatry system, which providers are held hostage to insurance and cannot find the time or resources needed for complex patients while ensuring we meet the quality and for the new modalities, so that particularly related to the direct patient care, not the medication cost itself, but the treatment modalities of providers?
Is that a question for anyone specific? Because I think Leah would be great to respond, but
I'm curious.
you want to start?
Sure. So I just want to make sure that I'm understanding your question really specifically. Would you mind just, I think I do, but I really want to understand what you're asking.
So the health insurance-based psychiatry model right now is already in crisis because of the fact that the providers, the insurance companies, are being held hostage, or holding the providers hostage because of the time that they need to spend with patients. And with such new treatment modalities, I'm understanding that the drug could be covered, but how do we plan on covering the services such as the psychiatrist and the psychotherapists?
Gotcha. Thank you so much. Yeah, so this is pretty much the reason that I started in Thea, and to address this issue specifically. So the infrastructure is really essential to helping to make sure that the treatment gets covered as well. You know, that the drug is not going to be approved if there's not a network of practitioners to actually deliver the drugs to patients. So that's why these healthcare infrastructure projects, they need to exist, and they also need to coordinate with one another in order for the healthcare system and the payers to get the information that they need in the field to make the decision to cover the therapies as well. I know that sounds really complex, but I'm telling you, we absolutely can do this. I promise you that we can. We just have to get involved. We just have to participate in the development of the infrastructure of the field so that it has a voice in this particular thing.
Well, I would love to help you.
Great.
Please do.
Thank you. Let's Let's take another question from the audience.
Sure. My name is Steve Rubel. I'm a psychiatrist here in Manhattan, and I just got trained in the ketamine-assisted psychotherapy, but I'm about to move in the direction of either Naropa or California, and I was just curious, to do the MDMA and psilocybin training. Do you know if there's any difference? Is there one size fits all in these? I like that there's experiential. I don't want to do online, so I'm curious, Michael, if you have any suggestion there.
My hearing is not great, but are you talking about the differences between training for psilocybin versus MDMA?
No, the facilities, the difference between Naropa and California.
CPTR.
I see, yeah. Well, they're quite similar, but I don't, I couldn't really recommend one over the other. I don't know the details of the Naropa one as well as I do the CPTR, because Marcella and Bruce, the investigators in Boulder and the trainers do that one, and we're doing the CPTR. So I don't know, but I think either one would be great.
All right, I appreciate it. Thanks a lot.
Let me just add, I think, Naropa is adding, I think starting next year, a whole track in psychedelic therapy. And embedded in that is, it was online this summer, but it may be in person as a retreat style.
Yeah, it is. It is
Yeah.
going to be in person.
Yeah, so it's going to be very similar to the CIS program that will probably have some online, and also the retreat style, which Michael and I did one of them this fall, and Marcella and Bruce did one in Boston because they divided up the cohorts. So those are both going to be very similar.
Great, I appreciate it. Thanks a lot.
Yeah.
Great, thank you. Let's take one more from the audience.
Hi, my name is Andy Atterbury, and I work in the field of medical cannabis, and I often think about the upcoming FDA approval of MDMA in comparison to FDA's approval of cannabis-based therapies like dronabinol and most recently Epidiolex. And my question is, much like those, do you anticipate that the FDA and the DEA will schedule MAPS's MDMA product differently than MDMA itself, if they'll pull a bait and switch, so to speak, at the time of approval without or descheduling MDMA itself because of the way your compound will be approved in the context of a very tightly controlled clinical administrative psychotherapeutic context?
I can speak to that. Oh, did you? Okay. So it is our expectation that if our drug product is approved, that our specific GMP-produced MDMA would be taken out of Schedule 1. And my colleague Jay Nair, I think, is here. I saw him at some point. He leads our chemistry, manufacturing, and controls team. So we've invested a tremendous amount in being able to produce MDMA at GMP standards. So that branded GMP product is what we would expect would get pulled out of Schedule 1. And MDMA, all other MDMA effectively would likely remain in Schedule 1. So that kind of bifurcated scheduling is what we expect, very similar, as you said, to Epidiolex or some other products that have faced a similar dynamic.
Thank you.
Thank you so much for that clarification, Joy, and thank you all for your wonderful questions. We're going to move on to our final segment of the day. Let's give these presenters a really beautiful, warm round of applause.